Most people talking about MTHFR make one of two mistakes. They either act like it explains everything, or they act like it doesn't matter at all. And the truth is, it's usually somewhere in the middle. If you have ADHD and you've been told you have an MTHFR mutation, or you're wondering whether MTHFR actually matters, this video is going to help clear that up. In this video, I'm going to break down what MTHFR actually does, what the common variants really mean, how this may or may not relate to ADHD, what labs I actually care about clinically, and why some people do very well on methylated B vitamins while others feel much worse on them. Welcome back. If you're new here, I'm Dr. Dan Sullivan. I'm a licensed naturopathic medical doctor, a certified functional medicine practitioner, and I also have ADHD myself. On this channel, my aim is to educate and empower using evidence-based medicine and a root cause lens, looking beyond medication alone to better understand what's really driving ADHD symptoms. Let's start with what MTHFR actually is. MTHFR stands for methylene tetrahydrofolate reductase. It's an enzyme involved in folate metabolism. More specifically, it helps convert folate into 5-MTHF, which is the active form used in a very important pathway that helps recycle homocysteine into methionine. That matters because this pathway is tied to methylation, and methylation affects a lot of things in the body, including neurotransmitter production, DNA synthesis and repair, and how efficiently certain nutrients are being used. This is one reason MTHFR gets so much attention. It sits upstream from processes that are important for brain health, detoxification, cardiovascular health, pregnancy, and overall mental health. But this is also where people start oversimplifying things. A gene variant is not the same thing as a diagnosis. And having an MTHFR variant does not automatically mean it's the root cause of your ADHD, your anxiety, your depression, your fatigue, or every other symptom you may have. What it usually means is that you may have a genetic tendency that is worth understanding in context. The question is not just do you have the variant, the real question is it showing up functionally in a way that actually matters in your specific case? Now let's talk about the two main variants people usually mean when they say I have MTHFR. The first one is C677T. The second one is A1298C. C677T is the one that's generally better studied and more functionally significant, especially when we're talking about reduced enzyme activity and elevated homocysteine. A1298C is usually considered the milder variant. It can still matter, but in most cases, it's less strongly associated with homocysteine elevation than the 677. This is where it helps to understand a few genetics terms. Wild type means you do not carry the variant at that position. Heterozygous means you carry one copy of the variant. Homozygous means you carry two copies of the variant. So for 677T, if your report says CC, that's the wild type. And if it says TT, that means homozygous. For A1298C, if your report says AA, that's the wild type. If it says AC, that means heterozygous, and if it says CC, that means homozygous. One quick note here because genetic reports can be very confusing. Some labs show MTHFR as C677T and A1298C, while others show the actual base pairs on the strand they tested, so you may see letters like AG or TT instead. That doesn't necessarily mean the result is different, it's often just a different way of reporting the same variant. So if your report looks different from what you see online, focus less on the letters alone and more on whether the lab is calling it wild type, heterozygous, or homozygous. Now let's talk about what that means functionally. For the C677T variant, heterozygous carriers, so CT, are generally thought to have about 65 to 70% of normal enzyme activity, which works out to a roughly 30 to 35% reduction. Homozygous TT carriers are generally thought to have about 25 to 30% of normal activity, which is a roughly 70 to 75% reduction. That's why TT usually gets the most attention clinically. For A1298C, the effect is generally milder. Heterozygous AC carriers are often described as having about a 15% reduction in activity, while homozygous CC carriers are often described as having about a 30% reduction. With that said, the clinical significance of A1298C is usually considered less severe and less direct than C677T. C677T usually matters more when we're talking about significant enzyme reduction and homocysteine. Now, how does this connect to ADHD? This is where I think people often go too far. There's some research suggesting an association between MTHFR polymorphisms and ADHD. A 2022 meta-analysis looked at C677T and A1298C across several psychiatric conditions, including ADHD, and suggested there may be an association between MTHFR variants and ADHD risk. There are also earlier case control studies looking at these polymorphisms in ADHD populations. But that does not mean MTHFR causes ADHD, and it definitely does not mean it's the main driver of ADHD in most people. ADHD is much more complex than that. ADHD is multifactorial. Dopamine signaling matters, sleep matters, nervous system regulation matters, blood sugar matters, stress matters, inflammation matters, gut health can matter, trauma and early environment can matter, nutrient status can matter, genetics matter too, but not usually in a one gene explains everything kind of way. So when I think about MTHFR and ADHD, I don't think of it as the answer. I think of it as one potential contributing factor in a subset of people. That brings us to what actually matters clinically. In practice, I care much less about the gene variant itself and much more about whether it's actually affecting downstream function. That means I care about things like homocysteine, B12, folate, MCV, symptoms, diet, cofactors, and the overall clinical picture. Because again, the real issue is not just whether the gene is present, it's whether the body is actually struggling to use folate and related nutrients efficiently enough downstream that it starts to matter clinically. That's why homocysteine is such an important marker here. Homocysteine is a very useful functional marker because folate, B12, and B6 are all involved in processing it. If homocysteine is elevated, that can suggest that methylation or one-carbon metabolism is under more strain. It doesn't tell you everything, but it often tells you more than a gene report alone. Then I look at B12 and folate. Now this is where we need nuance. Serum B12 and serum folate can still be useful, but they're incomplete on their own. A normal B12 or folate level on paper does not necessarily mean that the body is utilizing that nutrient efficiently at the tissue level. They assume that because their B12 or folate falls somewhere in the normal lab range, that everything is fine. But that's not always true. You can have a normal looking blood level and still have functional signs that methylation support or nutrient utilization is not optimal. That's why I don't interpret those numbers in isolation. Then there's MCV, which is mean corpuscular volume. This is included in a CBC or complete blood count and is basically a measure of red blood cell size. If MCV is elevated, that can sometimes point toward a folate or B12 issue because red blood cell maturation depends on those nutrients. Now, it's not a perfect marker and a normal MCV does not rule out a functional problem, but when I see elevated homocysteine, maybe some symptoms, a borderline or low normal B12 or folate, and MCV is pushed up as well, that starts to build a more meaningful picture. And B6 matters here too, because B6 is involved in homocysteine metabolism as well. So when I'm looking at homocysteine, I'm not just indirectly thinking about folate and B12, I'm also thinking about whether B6 is part of the issue. This is why I always come back to systems thinking instead of one marker thinking. This is also why I say what matters most is not whether someone has the MTHFR variant. What matters most is whether there is evidence that folate, B12, and B6 are not being used or processed efficiently enough downstream to start affecting symptoms, metabolism, or brain function. Now let's talk about supplementation because this is where a lot of people get tripped up. Some people take methylfolate or other methylated B vitamins and feel noticeably better. Their mood improves, their energy improves, sometimes even their focus improves. Other people take the exact same thing and feel awful. They feel wired, anxious, overstimulated, irritable, or like their nervous system is suddenly in overdrive. And this is one of the biggest reasons I don't like one-size-fits-all protocols. Just because someone has an MTHFR variant does not automatically mean they need high-dose methylfolate. And it definitely does not mean more is always better. One reason some people may react poorly is COMT. COMT stands for catechol O-methyltransferase. It's an enzyme involved in breaking down catecholamines like dopamine, epinephrine, and norepinephrine. The common polymorphism people usually talk about is Val-158-Met. If someone is Val-Val, that's generally the faster version. If someone is Met-Met, that's generally the slower version. The Met version is associated with reduced COMT activity, meaning catecholamines may be broken down more slowly. Clinically, what this can mean is that if someone already has a tendency to break down stimulating neurotransmitters more slowly, and then you give them a significant amount of methyl donors, they may feel overstimulated more easily. COMT is not the whole story either, and I would not reduce someone's response to one variant. But it is one reason that some people feel too activated on methylated supplements. The other reasons are often simpler than people realize. Sometimes the dose is just too high, too fast. Sometimes the person already has a very stressed or dysregulated nervous system. Sometimes they're sleep deprived, under-eating, overstimulated, or running on too much caffeine. Sometimes the balance of cofactors is off. And sometimes the issue is that the supplement is being pushed aggressively into a system that needs more foundational support first. That's why when someone reacts badly, I don't automatically conclude that methylfolate is wrong for them forever. But I also don't assume they should just push through it. Usually it means we need to slow down, lower the dose, reevaluate the form, support the rest of the system, and make sure we're not treating a gene report more aggressively than we're treating the person. And since we're on the topic of forms, I'll say this clearly. I'm generally not a fan of folic acid, which is a synthetic form of vitamin B9, especially in people where methylation is already a concern. That doesn't mean I want to fearmonger around it, but in clinical practice, I generally prefer food-based folate and/or 5-MTHF, because these are usually more in line with what I'm trying to support physiologically in someone where MTHFR may actually matter. So who should care more about MTHFR? I care more when someone has a meaningful clinical picture that fits. That could include elevated homocysteine, recurrent low or low normal B12 or folate patterns, strong symptoms that suggest methylation strain, medication sensitivity, significant mood issues, pregnancy or preconception concerns, or a clear clinical response to methylation support. I care less when someone simply finds a common variant on a genetic report, has no real symptoms or downstream markers suggesting a problem, and then starts treating that mutation like it explains their whole life. That's where I think people get led astray. So the main takeaway from this entire conversation is this. MTHFR is not meaningless, but it's also not the center of the universe. It can matter, sometimes it matters quite a bit, but what matters most is whether it is functionally relevant in your case. The goal is not to obsess over a single gene. The goal is to understand whether that gene is actually affecting folate metabolism, homocysteine handling, nutrient utilization, neurotransmitter support, and your overall clinical picture in a way that's worth addressing. And if it is, then we support it thoughtfully. And if you want to go one step further, I'd recommend watching this video here next on the top 3 foods to start your day with. Because understanding MTHFR is helpful, but knowing how to support your brain in a simple, practical way every day is where things really start to change. And if you'd like to work with me to better understand the root causes behind your or your child's ADHD symptoms and how factors like methylation, nutrient status, and nervous system regulation may be affecting you, check the link in the description to set up a discovery call.